Preventing hospital-acquired pressure injuries with the application of Meplex dressings, presented by Rachel Daniels, Courtney Seska, and Robin Sizz for the College of Nursing at the University of Hartford Quality Improvement Evaluation class taught by Dr. D'Amico. By the end of this presentation, we will have reviewed the importance of preventing pressure injuries using the Meplex dressing, recognized the team members involved, examined the change action, how it relates to Lewin's change theory, reviewed the model of improvement to be applied, identified the quality tools that would be utilized for implementation, demonstrate how to effectively protect our patients from pressure injuries. We will point out various stakeholders and discuss how the success of this project will be measured. Chronic wounds are a growing healthcare concern, especially considering the aging population and patients with contributing comorbidities such as diabetes, hypertension, peripheral vascular disease, and heart disease. Patients with chronic wounds require complex care, which accounts for billions of dollars in healthcare costs. Prevention is key. Creating a customized plan beginning with the initial hospital assessment allows healthcare providers to be proactive in managing this issue. An evidence-based approach to pressure injury prevention created by a multidisciplinary team includes skin and risk assessments, visual and electronic health record cues, prophylactic protection of at-risk skin, communication amongst providers and leaders regarding patient risk and injury throughout hospitalization, staff education, compliance audits, root cause analysis, and wound care team follow-up. The Plan Do Study Act is a rapid cycle improvement model that improves the process to carry out change. When applying PDSA, 3 questions are answered. What are we trying to accomplish? What changes result in improvement? And how will we measure the improvement? In the plan phase, we describe the problem, identify causes, acknowledge who is involved, and recognize the goal. In the second stage, Do, we implement the plan. Stage 3, Study, will allow us to evaluate if the plan resulted in the improvement that we're looking for. And Stage 4, Act, standardizes the plan for regular usage or determines if a different approach would be more successful.
Through discussions with my groupmates, it was determined that a change that was implemented in one of our institutions was the placement of a protective Meplex on a patient's coccyx or other pressure spots for patients who are identified as being a high skin risk. A high skin risk is determined through the use of Braden scale, which uses various factors to determine if someone is at risk for development of a pressure injury. If someone is classified to be a skin risk, a protective Meplex will be placed to high-pressure areas, such as the coccyx, to prevent the development of a pressure injury. This can occur at any point during a stay, but should occur on admission or transfer to a different unit. In procedural areas, such as the operating room, Meplexes are placed on pressure areas determined by the position that the patient will be laying in during the procedure. The Braden score is based off of a scale determined by the nurse on a daily basis using 6 classes. First, sensory perception, which is the ability of the patient to respond to pressure and discomfort. Second, moisture, which is the degree that the skin is exposed to moisture. 3, activity, the degree of physical activity that the patient can tolerate. 4, mobility, the ability of the patient to change and control their positions. 5, nutrition, their usual food intake. And 6, friction and shear, which is the assistance needed to reposition. Each of these topics can be scored from a range of 1 to 3 or 4. The lower the score, the more at risk for development of a pressure injury the patient is. A score of 15 to 16 is considered low risk. 13 to 14, moderate risk, and below 12 is high risk. When a patient is considered high risk, there are numerous nursing initiatives that can become implemented. First, the skin risk, which triggers nursing to place the patient on a low air loss bed and initiate frequent turning and repositioning. The newest change in the institution is the implementation of placing a protective Meplex on a patient's coccyx or other bony prominences. Lewin's change theory is based off of Kurt Lewin's model, in which he theorizes 3 stages of change: unfreezing, change, and refreezing. As seen above, the unfreezing stage is when a method is found to change individuals' old habits. This was done, for instance, in this situation, by providing staff educational and evidence-based practice information about the reason protective Meplexes were so important. The change, obviously the most important, is when individuals' thoughts and feelings move from the old, less productive initiative to the new practice. This did take some time, but eventually staff members saw how important placing these protective Meplexes were. The unfreezing stage is imperative to the change being effective. The refreezing stage is when the change has been established and welcomed by staff and is now a habit. Once staff make placing the protective Meplex a habit, the rate of hospital-acquired pressure injuries may decrease.
With any quality improvement project, the application of quality improvement tools is essential. Quality improvement tools help set goals and benchmarks. They search for the root causes of the problem, point out where to focus change, and help measure outcomes. This quality improvement proposal will use 3 important tools to determine if the utilization of Meplex dressings is useful in preventing pressure injuries. First, the team will be collecting data from both internal and external databases to help create goals and benchmarks. Next, our team will conduct a fishbone diagram to identify the root causes of the problem. Lastly, the team will create a Pareto chart, which will help decide where the focus of change should take place initially. The first quality improvement tool our team would like to introduce is the collection of data from 2 different areas. First, the team will collect hospital data from internal databases from over the last 2 years. We will retrieve data pertaining to pressure injury scores specific to our unit. Secondly, we will collect national data pertaining to pressure injury scores. According to Amen and others, a facility's access to a national reporting database, such as the National Database of Nursing Quality Improvement, or Centers for Medicare and Medicaid, and the Agency for Healthcare Research and Quality. What these databases allow, or the access to these databases, allows hospitals to not only view their data pertaining to quality indicator scores, such as pressure injuries, but also other hospitals. This encourages hospitals to improve their patient outcomes through setting standards and benchmarking. The goal of this quality improvement tool is to compare project data and outcomes to national data to determine if our change action has been successful or not. Next, I would like to go over a fishbone diagram. This quality improvement tool will be used to determine the cause or causes of the problem. This type of quality improvement tool falls under the category of cause and analysis. According to Nash and others, once a gap in quality has been discovered, the next step is to determine why care is falling behind benchmarks. This is also called the cause and analysis. Nash and others go on to explain that a cause and effect diagram, also known as a fishbone diagram, can expand the search for possible root causes of the problem. because sometimes a problem can have multiple causes. The problem or effect is stated in the triangular box in front of the causal factors. In this case, the problem or effect is an increased amount of pressure injuries on a particular unit. There are 4 causal headings within this fishbone diagram where possible causes could be contributing to the increase of pressure injuries. We have picked out 4 causal factors: team, patient, documentation, and service line. There could be problems linked to our change action from any one of these factors. For example, let's take a closer look at factor number 3, documentation. Under the heading documentation, there could be a few root causes leading to injuries, such as a low usage of documenting in the Braden scale, or not using the Braden scale at all through one shift, or not documenting high-risk skin areas on admissions. If these 2 interventions are not being done, then nurses will have a difficult time identifying which patients should have a Mepilex dressing on to help prevent pressure ulcers throughout a hospital stay. Pressure injuries can happen on multiple bony surfaces, such as heels, coccyx, ankle, ears, elbow, head, and hips. When you have multiple areas that are being impacted, placing them on a Pareto chart can be very useful. According to Whitman and others, the Pareto chart is based off of the Pareto principle, which proposes that 80% of the problem stems from 20% of the causes, called the vital few. Let's use our problem, the increase of pressure injuries, to understand the Pareto chart. Places of pressure injuries are identified along the horizontal bottom line. Column B, heel injuries, and F, coccyx, has the most occurrence of ulcers. The vertical right side of the chart explains the cumulative percentage of the occurrences, and the vertical left side of the chart details the number of actual pressure injuries. One can conclude that by looking at this basic Pareto chart, that the heels and coccyx are 80% of the vital few that need to be investigated and concentrated on initially. This is where the majority of our problem or causes come from. We can determine by looking at the chart that the vital many are the other sites that certainly need to be addressed, but are considered an easier fix or not as immediate. Those would be the remaining sites: ankles, ears, elbow, heads, and hips. This tool points out exactly where our team should concentrate first. We should concentrate on heels and coccyx. If we are assessing our patients and putting forth our interventions that are necessary to identify high-risk patients for pressure injuries, then we should be applying Mepilex dressings. If we're utilizing those Mepilex dressings, then our Pareto chart data should point out a reduction in pressure injuries in the heels and coccyx category, since that's where we're going to start first. We will then concentrate on the ankle, ears, elbow, head, and hip. Certainly those are areas that are very important, but we see they're not contributing too much to the problem. Certainly need to be fixed and looked at. Now that we've gone over the 3 important quality improvement tools that will be used for this project, let's take a look at stakeholders involved in this change action. We have 5 identified important stakeholders: patients, healthcare facilities, Center for Medicare and Medicaid and third-party payers, nurses, and providers. Number 1, our patients. A patient's health is directly affected by pressure injuries. Plans that are put into action to help prevent hospital-acquired pressure injuries will result in causing no harm to patients and will keep them healthy during their hospital stay. According to Nash and others, patients do view technical performance and interventions as outcomes of care. Therefore, if we are preventing pressure injuries to patients and their loved ones, those technical skills and interventions will be deemed as good quality care. Healthcare facilities are invested in preventing pressure-related injuries for a few important reasons. One, they're not getting reimbursed from the Center of Medicare and Medicaid for preventable stage 3 and stage 4 pressure injuries, so they can lose money. Secondly, public mandatory reports have increased public knowledge surrounding this topic, and facilities want to maintain good grades on their institution. Center for Medicare and Medicaid and other third-party payers are concerned about unnecessary increased healthcare costs related to pressure injuries. The United States healthcare system spends roughly $11 billion annually related to pressure injuries and its secondary related complications. These are preventable events that drive up unnecessary healthcare costs. Let's take a look at nurses. Although pressure-related events are not solely related to nursing care, however, it's important to look at that there are numerous nursing interventions that can help reduce the risk of patients developing these injuries. Also, nurses are key team players in developing frontline solutions and strategies in preventing pressure injuries. These solutions have a direct effect on healthcare costs, a patient's health, and important nursing achievements such as a magnet status. Lastly, let's take a look at providers. Providers are key stakeholders. As like nurses, they have the ability to prevent injuries and help develop solutions which impacts the cost of healthcare. They are also being held accountable for value-based service, which equals increased quality of care with decreased healthcare costs. They also want to be known and affiliated with medical institutions that consistently get reimbursed for medical care from third-party payers. Next, I'd like to discuss the measurement of success. We will monitor internal data quarterly, data from our unit and other units throughout the hospital, and compare it to national standards and hospital goals that we have set. We will also use the Pareto charts to help us organize our data. We will survey staff quarterly and determine if any barriers to using Mepilex dressings do exist. We will hold quarterly unit meetings to discuss the results and to implement any change that might be necessary. In conclusion, we have reviewed the importance in preventing pressure injuries in the acute care setting. We have discussed both the integral team members and stakeholders involved. Staff can now relate the action change to Lewin's change theory. We have demonstrated how to effectively utilize and assess for the use of Mepilex dressings and its role in protecting patients. We have identified quality tools that will be used for this project, and we have reviewed how this action change will be measured. We want to thank you for listening to our presentation, and on the next slide, you can view our references that have been used for this presentation.